Thank you everyone for joining us. As Priya mentioned, today we have a second session on methadone and focusing mostly on case-based discussion, an experience-based discussion, I must say, which we have been using methadone for past few years. We have Dr. Sunil. Dr. Sunil is the Regional Director of Pallium India, and he's working in palliative care for nearly 20 years now. He has done his MSc in palliative medicine from Cardiff, and he is, I think, from the starting of procuring methadone years back. Since then, he's involved in using, dispensing, talking, and taking sessions, spreading awareness about how to use methadone. So today's will be mostly case-based learning, an interactive session, not completely a didactic. Thank you so much, sir. Over to you, sir.
Thank you, Sridevi. I think Theo also has joined.
Sorry, sir.
Yes. Dr. Theo is also joined us.
Theo, welcome, because Theo was introduced. I was also introduced in the last session. So welcome to Theo also. Okay,
Sorry, Theo, I didn't know that you were logged in for the session. Thank you so much, and welcome to the session.
Okay. So today it is mainly focused on sharing our experience on using methadone, because methadone would be a newer medication for many of you. And I know that only a few centers in India uses methadone. So it is important to understand how the people who started earlier have gone through, what were their problems when started patients on methadone, and how did they overcome, so that you will have some experience when you start patients on methadone. So that's the intention of this session. Okay, so I am straight away going to a patient story. And I would like all of you to be very interactive, because many of these things has to be done by you. So this is about a woman who is 30-year-old with a wing sarcoma. So in 2016, she was diagnosed with a wing sarcoma in the sacral area, for which she received chemotherapy and radiotherapy. And she was comparatively okay for 2 years. Then after 2 years, she had pain on back and legs. And because of this, her oncologist advised an MRI, and which showed disease progression with extension from S1 vertebral body. There was also compression of L5 and S1 muscle, and PET scans showed pleural metastasis. So this is the pain pattern of the patient, and this pain is at rest. Patient is complaining of low back pain, which is burning, and sometimes it is like shooting. And she has relief on lying down, and also increases with movement. Because of this, she was unable to move out of her room. And 1 minute. So because of this, she was unable to move out of her room. And actually, she was staying in the first floor of a house. Um, and she was also unable to sleep. You can see the pain score at rest, but on movement, all this becomes 10 by 10. You know that we cannot lie down without moving. So most of the time, the pain score is 10 by 10. And these are the medications she was getting. from another palliative care center. She was receiving tap morphine 10 milligram QFRH and SOS, and amitriptyline 75 milligram HS, pregabalin 150 milligram BD. And um, she was with these medications without any pain relief. So, what would you do if the patient has no pain relief with these medications? She is on morphine, amitriptyline, and pregabalin. And from the pain description, we can see that it is mainly neuropathic pain. So, what would you do now? You can either unmute and speak, or you can give your answers in the chat. Okay, I can see one answer: increase morphine, steroid, or reassessing, yeah, steroids. Okay, I also wanted to say that I have not mentioned all the treatment that she has undergone here. She was given steroids many times without any pain relief. And actually, they were unable to increase the dose of morphine because of toxicities. So what else can be done? Change to methadone. Yeah, sublingual buprenorphine. Okay. So all this can be done, but most probably, except I think sublingual buprenorphine has not tried. Otherwise, all the other medications has been tried on this patient without any pain relief. So probably sublingual buprenorphine is not going to be an option because it also has the almost has the same properties as of that of morphine, even though it is a partial agonist. Interventions. Dr. Abel says interventions. So what interventions can we do for this patient? So the treating team, they did an epidural catheterization and continuous epidural analgesia with propiocaine and morphine. So initially, patient had some pain relief for 18 hours, but it gradually weaned off in another week, and there was very mild pain relief. So you can see with that mild pain relief, even that was what the patient wanted, but we also know that we cannot keep the epidural catheter in a place for long. So they reinserted epidural at several places, and they continued it for almost 2 months. But ultimately, they had to take out the epidural catheter because that was not giving satisfactory pain relief also. So they decided to take out the epidural catheter, and they started the patient on morphine 20 milligrams 4 hourly and SOS. The next day they removed the epidural catheter and increased the morphine dose to 40 milligram Q for and SOS. Amitriptyline 25 milligram HS, and later to after titration it was increased to 75 milligram. Then pregabalin was titrated up to 150 milligram BD. No satisfactory pain relief. Patient had delirium and myoclonus. So this is the pain pattern which I have showed you earlier. So this is the stage when the patient actually came to us, and uh, so our plan was to start on methadone. So before starting methadone, what all should you check, or what all should you ask? Anybody? Yeah, ECG. Anything else? Serum, potassium, calcium, magnesium, LFT, history of cardiac disease, electrolytes. Yeah. Uh, yeah. Anything else to specifically ask the patient? Concomitant drug intake. Yeah, very good. All these are relevant questions. Yeah. But there are two more things which you should ask. Uh, is there any family history of sudden unexplained death in the family? Because congenital QT syndrome can also occur. And is there a reliable caregiver to administer methadone? So these are two questions which we need to ask. Then, as you told, ECG, which we did, the QTC was within normal limits. Electrolytes, calcium, potassium, magnesium was also within normal limits. So we actually this was one of the early patients, or I think this patient was the first patient which for whom we started methadone. So we were not sure what method we have to use for this patient. So we looked at the literature, how to start methadone, even though we had some teaching regarding methadone. But when we looked at the literature, these were the methods that was described in literature. You can see 5 methods here, and the first one, 3 day switch, that is 3DS, 3 day switch. 3 day switch means um, you will convert the dose of methadone, full dose of methadone, uh, into or you will divide 1/3 of the give 1/3 of the methadone on the first day. Second day you will give 2/3 of the methadone, and on day 3 you will give full dose of methadone. And likewise, on the first day you will reduce the total dose of morphine by 1/3. Second day you will reduce it by 2/3, and third day you will stop morphine. So that's known as 3 day switch. And there is another two method, rapid conversion, stop and go method, ad libitum, stop and go method, German model, outpatient titration. So all these are these were new to us. We didn't know what to use, and we also knew that many people uses 3 day switch, and even when we had classes on methadone, people were advising on 3 day switch. So again, we were thinking which would be a better method. So we again looked at the literature. So this is a systematic review which says there is currently no consensus on which is the safest and most effective method for rotation to methadone from another strong opioid. So then we thought, okay, we were taught on 3 day switch. So we would go for, we would try like that. So next was, what is the dose of methadone we have to use in this patient? Can anybody tell what is the dose of methadone we have to use? This is the medication that the patient was receiving. Can you calculate the dose of methadone that we need to use for this patient? Theo already in the last class showed us how to convert morphine to methadone. Five milligram BD. Okay, Abdul says 5 milligram BD. Anybody else? Maximum 40 milligram. Yeah, that's right. So 5 milligram. Tina says okay. 2.5 milligram twice a day. Okay, can anybody unmute and tell me how did you calculate the dose of methadone?
So there are two answers also to your question.
Yeah.
5 milligram.
Yeah, I saw the.
Can you see the chat? Okay, okay.
Yeah, yeah. So can anybody unmute and speak? How did they get that answer? Dr. Adul?
Yes, sir.
Yeah. Can you tell us how did you get 5 milligram daily?
So the conversion was taught in last class. Like
Yeah, yeah.
if it is below 200 milligram of
Mm. You are muted. Please unmute yourself.
if it is below 200 milligram daily, you have to use a formula, and if it is above 200, a different formula. Like
Yeah. So here the total dose of morphine is 40 milligrams before isn't it? So at least she is taking 40 into 6, that is 240 milligram. So if the patient is taking more than 200 milligram of morphine, or if the patient is above 65 years old, we have to use the conversion ratio 20:1, isn't it? So 20:1 would be here 240 divided by 20, that is um, 12 milligram. So probably that's why Adil told us it should be 5 milligram daily. Okay. So okay, but during that time, when we started patient on methadone, that the white paper consensus method was not available, and this was the ratio, equivalent ratio that was used during that time. You can see if the patient is consuming morphine between 100 to 299, the initial ratio is or the conversion ratio is 8:1. So what would be the dose? Here, patient is taking total morphine 240 milligram, and as the conversion ratio according to this would be 8. It will be about 32 milligram, rounded it to 30 milligram for easy calculation. And that is something called as incomplete cross tolerance. That means we have uh, potencies for each opioid, but when you convert from one opioid to another opioid, you will not give the full dose that we have got after conversion. It is because different opioids act on opioid receptors in different way. So 30 percentage can be reduced for incomplete cross tolerance. So from 30 milligram, you have to reduce 9 milligram, which is the 30 percentage of 30 milligram. So the total dose of morphine that we need to start is 21 milligram. Okay. So if we use 3 days switch, the total dose of methadone is 21 milligram. So on the first day, what should be the dose of methadone that we give this patient? Anybody? So on the first day, we have to use 1/3 of the total methadone. So what would be the dose we have to start on the first day?
7 milligram.
Yeah, 7 milligram. So what would be the dose of morphine on the first day? What would be the dose of morphine? So this is how it looks like. On the day one, you have to give 1/3 of the total dose of methadone. So it is 7 milligram. And on first day, you have to reduce the morphine by 1/3. So it is 160 milligram of morphine has to be given. And on day second, you will add another 1/3. So 7 plus 7 milligram, 14 milligram you have to give. And morphine you have to reduce by another 1/3. So only 80 milligram you have to give. And on day 3, you will give full methadone, that is 21 milligram. And morphine would be stopped. So this is what is known as 3 days switch. Okay. So um, we were actually very afraid of starting Methadone because we knew that it have many side effects, many interactions, and it was a new medication for us. So because of this issues, we didn't actually follow any of the advised methods, and this is what we did. On the day one, we actually started patient on one third of the total methadone, that is 2.5 milligram TID, and morphine we reduced by one third. So it may from 40 milligram, it came down to 25 milligram Q for X. So with this uh, methadone, patient was able to sleep. But we did not convert one third on the second day. Instead, what we did was we waited till day 7, and then only we added another one third. So we made it 5 milligram TID, and then we reduced one third of the morphine and made it 15 milligram Q4X. And patient pain relief was improved. And on day 14, we converted whole of the methadone. We gave full dose of methadone, that is 7.5 milligram TID, and morphine was stopped and made it SOS. So this patient had excellent pain relief. So if you remember what I told you, this patient was in the first floor of a house where she was restricted to the 4 walls. But actually, after 14th day, when we called her for assessment, she told that I will come to OPD, and patient came to our OPD by walking. Uh, the patient who was unable to even move actually came to our OPD by walking by herself. So that was the type of pain relief that she obtained after giving methadone. Okay. So from this, we can understand how apprehensive we were to start patient on methadone. So our team had 7 or 8 doctors, and all of us were very afraid to start patient on methadone. Even though methadone was available to us, it took long time for us to start a patient on methadone. Okay. So now we'll move on to second patient. So this is a 37-year-old man who was diagnosed with carcinoma of the buccal mucosa in 2018, and he again diagnosed with the second primary, that is papillary carcinoma of the thyroid, for which he underwent surgery and radiation. But in 2019, he had a level 2 nodal recurrence, for which he underwent surgery. So you can see this patient, how he is sitting with his head down. So his pain description is that the pain starts on the inside of the left ear, and it go back to the lateral side of forehead and then to submental region. He described it as pricking pain 10 by 10, and the treating team, they did an extraoral mandibular nerve block, and they did it thrice, and there were no pain relief. You can see this is the pain pattern. The pink colored area is the place where the patient has pain. So you can see that from the neuroanatomical distribution, it is in the mandibular nerve area. So it is a neuropathic pain. But even with the mandibular nerve blocks, patient did not have any pain relief. So what they did was because external mandibular nerve block was failed, they tried with injection morphine, and it produced toxicity. So they reduced the injection morphine and started on tablet morphine like this: 10, 15, 10, and 30 milligram and 10 milligram SOS. Even with this, patient had severe morphine toxicity and no pain relief. and they tried him on various adjoint analgesics. And when he came, these were the medication the patient was taking. Tab morphine, pantoprazole, ciprofloxacin, escitalopram, steroidopeptidase, diclofenac patch one every day, tab paracetamol 650 milligram 1 ss. So can anybody tell me? We decided to start this patient on methadone. So what are the indications to start the patient on methadone?
No relief.
Okay, yeah. Opioid toxicity. Other says opioid toxicity. No
Morphine
relief.
toxicity.
Yeah, yeah. Severe pain. Mm, okay. Anything else? Anything else? Neuropathic pain. Yeah. DSM. Opioid tolerance. Okay. Opioid tolerance. I'm not sure because this patient is taking only 10 milligram on 4 hourly. So that is not a big dose. So let's see what are the indications. So one is complex neuropathic pain. Patient was tried on various adjuvant analgesics. He underwent mandibular nerve block. No pain relief. So complex neuropathic pain, morphine toxicities, and not responding to other opioids. Here they tried him on tramadol and morphine. So these are the indications to start patient on methadone. So before starting methadone, what all should be done? So likewise, in the previous patient, we have to ask about the sudden unexplained death in the family. Is there a reliable caregiver? ECG and electrolytes, do we actually need it? So uh, from the previous session, we know that the investigations and how much monitoring should be done to a patient. It all depends on the goals of care for the patient. So you can see that this patient doesn't fit, he's not fit for any oncological interventions, and he is only for comfort care. So actually, we need not do ECG or electrolytes, but maybe it is good to have ECG and electrolytes when you start the patient methadone for the first time. So, any of you have any concerns with the present medications? These are the medications he is getting. Any of these medications has any interaction? Ciprofloxacin, yeah, ciprox. Yeah, I can see. Yeah, I can see many people are talking about
Citalopram.
Escitalopram. Yeah. Okay. So escitalopram and pantoprazole even have some interaction with uh, methadone and also ciprofloxacin. So we know that the ciprofloxacin and the fluoroquinolones and macrolide antibiotics, those should be stopped, and we should select alternatives. And SSRIs like citalopram, citalopram, all those have interactions with methadone. So we have to convert this morphine to methadone now. So what would be the dose of methadone that we have to use in this patient? 20 milligram. Okay, 2.5 milligram BD. Yeah, Abdul and Prakash says 2.5 milligram BD. Okay, let's see. So he is taking total 65 milligram of morphine. You can see 10, 15, 10, and 30. So total he is taking 65 milligram. This is not the way to start morphine, but the treating team did like this because they were a fine balance in the pain relief with toxicities. And the patient's age is 39 years. And oral morphine equivalent, total he is taking between 60 to 199. So the conversion factor is 1 by 10, and you can start patient on 6.5 milligram. So if you have only tablet methadone, you can start 2.5 milligram daily, or syrup methadone 3 milligram daily, and morphine 10 milligram Q for on SOS basis. So the prescription would be like this. Paracetamol, instead of ciprofloxacin, you have to select any other medication that doesn't have much interaction. So amoxicillin and bisacodyl. And this patient was started on escitalopram because the treating team did it, and because there were no pain relief. So they thought that patient was in depression. But actually, it was the physical pain that was making more problem for the patient. So when we started him on methadone, we stopped escitalopram and um, actually with methadone he had very good pain relief. So this is how we started him on methadone. On first day we gave him 2.5 milligram BD as you suggested, along with the tab morphine 10 milligram Q for SOS. And after 3 days, we increased another 2.5 milligram, which with which actually he had a very improved pain relief. And on after 5 days, we increased it to 3.75 milligram. So you can note here, we even went on to start patient on 3.75 milligram because we were afraid. Otherwise, we would have given maybe even 4 milligram or even 5 milligram. But these were one of the early patients of us. So we were really afraid to give methadone. But the story is that this patient had a very good pain relief. So you saw the patient how he was keeping his head um, down the table, and we actually didn't think that he will get pain relief. But within 3 days, we could see the magic, and we were able to send him home. And till his death, he was pain-free, and he was able to visit many places that he actually wanted to. So that's another success story. So now I will move on to another patient. This is again a 39-year-old woman who has carcinoma of the pancreas stage 4 with liver, lung, and splenic metastasis. She received 5 cycles of chemotherapy, but the oncologist told her that her disease is progressing uh, even with chemotherapy. So they discontinued the chemotherapy, and she was receiving palliative care from the oncologist. So you can see this is the pain pattern. The pain she describes, it starts on the left lateral aspect of the chest, and it radiates to back for the last 2 months, and it is a continuous type of pain, and it is mostly 10 by 10. And she says it is a stabbing pain, and the movements actually increases the pain. The palliating factors are when the patient lies down on the right side, then with injection morphine, tramadol, and paracetamol. When she takes all of this, her pain come down to 7 by 10. And she was unable to sleep and depressed. And she actually has 2 children. Very worried because she was unable to do anything for her children. Bedbound or bedridden because of pain, and she was a nurse. So these were the medications she was taking. You can see tab morphine 20 milligram, 6 hourly, injection tramadol 100 milligram IV TID, paracetamol 1 gram 6 hourly, gabapentin 100 milligram TID, amitriptyline 25 milligram HS, bisacodyl 5 milligram 2 HS. And we even with this morphine, she had myoclonus. So do we need any investigations? What are the conversion factor? And do we need to change any other medications? So do we need any investigations? So you have to answer what is the goals of care in this patient. That is comfort care, isn't it? What are the indications to start methadone? Neuropathic pain, morphine toxicities, and even the patient was taking tramadol and morphine. So refractory to other opioids. So these were the indications to start methadone in this patient. So how do you calculate methadone dose? So she was, can anybody tell me what would be the dose of methadone we have to start in this patient? This is the medication that she is receiving. Please calculate, I will give you 2 minutes. Oh, I can see the answers are coming. Adul is very fast. 2.5 milligram TID. Yeah. Yeah, please calculate the dose of methadone that we need to start. We'll talk about drug interactions later. Okay, I can see various doses here. Okay, good. Let's see. Yeah. So this patient is taking 20 milligram of morphine every 6 hourly. So the total dose of morphine would be 80 milligram per day. But we also need to understand that she's also taking injection tramadol. So you have to convert tramadol to morphine. That is the equivalent dose of morphine. So what would be the oral morphine equivalent of tramadol? So she was taking 100 milligram TID. So total dose of tramadol she is taking is 300 milligram. And conversion or potency compared to morphine is it is 1:10. So you have to divide by 10. So total the tramadol the oral morphine equivalent is 30 milligram. You have to add both. So it is a total 110 milligram. And the conversion factor would be 10:1 because she is receiving morphine between 60 to 199 and age is 39. So it is methadone dose would be 11 milligram. So you can start with tab morphine, tab methadone 5 milligram daily. So any concerns with the present medications here?
Amitriptyline.
Yeah, amitriptyline. Amitriptyline has some interaction with methadone, but you can see she is receiving only a small dose. So either you can stop it or you can continue. It doesn't make much difference here. So you can see we started her on methadone 5 milligram daily along with morphine 20 milligram Q for on an SOS basis. We continued gabapentin and amitriptyline. And this was one of the patients who actually spent her last 2 months of life very she enjoyed the last 2 months of life. The patient who was bedridden due to pain after starting methadone, she was able to do all those things that she wanted to. And actually, she attended her and she actually conducted the first Holy Communion of her children. And she was very happy because she was unable to do anything. and she had a very good pain relief, and she lived very good life with methadone.
Sir, one doubt I have to ask them, Dr. Ragesh. Do these patients require tab morphine as SOS, or it was controlled with methadone only?
They would require SOS dose of morphine, because in between they can have breakthrough pain. So for breakthrough pain, we usually advise the patient to take morphine, not methadone. Is it clear?
Patients, so these patients required morphine after starting methadone also.
Yeah, for the first few days, maybe 5 to 7 days, she might require SOS doses of morphine, but after that, usually they may not require morphine, but we need to expect breakthrough pain can occur.
So what will you do in case patients having morphine toxicity or any allergy to morphine? We cannot give morphine along with methadone, no?
Yeah, in that case, maybe you can continue with the methadone, and I'm not sure about whether tramadol is something which we can give, because if they are chemically different, I think the Theo would be able to answer that question. Theo, do you know tramadol and morphine come in the same chemical group?
I would need to double check with cross reactivity, but I believe tramadol doesn't fall in the same group. But I would say the caution with tramadol is because that acts on the serotonin and norepinephrine. There may be increased risk of serotonin toxicity with the combination of the two.
Yeah, so Dr. Rajesh, I think Tia will check and tell us.
Okay,
If we are in different chemical group, then we can give tramadol considering our situation, because we do not have any other medication that we can give orally. Maybe buprenorphine is another choice, but um, even I would not give buprenorphine. Serotonin syndrome is something which we need to be aware, but I think it is very rare, but it occurs usually with MAVO inhibitors, which nobody uses it now. Okay, now I am moving on to another patient. So this is a 41-year-old man with retrovirus positive on heart therapy. And this patient was seen by us for pain on the right upper limb and chest in 2010. And he was given optimal doses of adjuvants and morphine. But this, when we started him on morphine, that caused right hypochondrial pain. Can anybody tell me what is the problem? Why this patient has right hypochondrial pain?
Oh, sorry to interject, Dr. Sunil. So another option would be fentanyl, which is synthetic also, which shouldn't have the cross reactivity with the morphine that could be used.
Yes, Theo, but that would be very difficult, isn't it? Because that fentanyl would be continuously releasing, which is not SOS. So that's
sorry, like in a, if it was in an inpatient setting, that would be an option.
Okay. Thank you, Theo. What is the cause of this right hypochondrial pain in this patient? Liver abscess, yeah, cholecystitis. Yeah, any other answers? Okay, so this patient, whenever he was given morphine, he will complain of right hypochondrial pain. And when we tried him on Buscopan, that is injection hydroxybutyl bromide, the pain reduced. So this is a very rare phenomenon that occurs in patients who are on morphine, and it is due to sphincter of Hodge spasm, which I told you is very very rare. I have seen only one patient uh, who got sphincter of Hodge spasm, which produces right hypochondrial pain. Uh, so we cannot give morphine in this patient. Uh, so we actually investigated this patient and found out that there is a soft tissue lesion on the right of midline, which is extradural, and it was diagnosed as diffuse large B cell lymphoma. So a patient who has HIV with malignancy, diffuse large cell lymphoma. So this is about a sphincter of Hodge spasm. It presents with recurrent biliary pain. They say it is a disabling epigastric or right upper quadrant pain lasting for 30 minutes to several hours with or without hepatic enzyme elevation. And this may radiate to back, shoulder, or scapula and may be accompanied by nausea, vomiting, mimicking a gallbladder attack. And it is not consistently postprandial and is not relieved by postural changes and acids or bowel movements. And there are, when I look at the literature, they have suggested many medications like nifedipine, calcium channel blockers, then glyceryl trinitrate, and anticholinergics. So this patient, we would not be able to give morphine because of sphincter of Hodge spasm. So he received chemotherapy and radiotherapy, but in 2014, the pain recurred, and probably it would be a recurrence, but there was no treatment taken. The patient was tolerating tramadol and other adjunct analgesics. So we continued him on tramadol and adjunct analgesic. You can see this is the pain pattern. Pain on the shoulder area and whole of the right upper limb. So he came to us with increased pain, catching type, and tramadol gives very little relief, and you can see the pain score. He is unable to do any activities of daily living, and he was unable to earn anything because of this disabling pain. So you know that this patient is on heart is highly active antiretroviral therapy, and many of the ART medications has interactions with methadone, but he was taking ART medication which doesn't have interaction with methadone. So we started him on methadone 2.5 milligram BD, and we gradually increased so this was a patient who was on methadone, and we directly jumped on to who was on tramadol, and we directly jumped on to methadone, starting with a very low dose of 2.5 milligram BD. So you know that in opioid naive patients, the dose advised is 2 milligram to 7.5 milligram to 2 to 7.5 milligram per day, or even if you calculate the equipotent, when you convert tramadol to oral morphine equivalent, it would be less than 60 milligram. So this dose would be good enough to start with 2.5 milligram BD. But then we titrated and increased it to 2.5, 2.5. So you can see it is 25 plus 15, that is 40 milligram of methadone. And he is actually a driver. So if he is able to work as a driver with methadone, he is not drowsy or something like that. He is very active. So he's on disaccordile, enalapril, ranitidine. He is also diabetic, so on human mixture and heart therapy. So in the TS presentation, we had about methadone can be used as an adjuvant. So this is the patient for whom we use methadone as an adjunct. So you can see this is a 62-year-old man with just gastrointestinal stromal tumor, for which he underwent a laparotomy and excision. And you can see the pain pattern. Pain is there for the last 1 month, which is continuous. Pain score is 5/10. And he was started on tramadol 50 milligram TID. And later, because of poor pain relief, the patient was started on morphine 5 milligram Q4H and SOS. Then titrated up to 30 milligram Q4H and SOS. June 2022, it was increased to 40 milligram Q4H and SOS. But he had he developed myoclonus, nightmares, and pain relief only for 1 hour. So we again reduced the dose to 30 milligram Q4H and SOS, and he didn't had a proper pain relief. So we thought of adding syrup methadone, a small dose along with morphine. So syrup methadone 1 milligram TID was given, and he had no toxicities, and he had very good pain relief. So this is how adjuvants or methadone can be used as an adjuvant. So if you use small dose of methadone along with other opioids for better pain relief, that is it is called as an adjuvant. That's all. So we will move on to another patient. So 65-year-old man with a malignant melanoma and lung metastasis. He completed 11 cycles of chemotherapy and 6 fractions of radiotherapy. And he is complaining of pain for the last 1 month. You can see the pain pattern. It looks like neuropathic pain, which is intermittent, 6/10, aching, increases with movements, decreases lying on the other side. Okay. And he was started on morphine 5 milligram Q4H, sodium valproate 200 milligram TID, imipramine 25 milligram HS, and this patient was comfortable for 4 months. And in December 2020, you can see this patient came to us in April 20, and by December 2020, the morphine dose was titrated up to 25 milligram Q4X and SOS, sodium valproate 900 milligram, tab imipramine 75 milligram HS. No satisfactory pain relief. So we decided to start this patient on methadone. So tab methadone, this was 25 milligram Q4X. That means this patient is taking what 150 milligram, isn't it? 150 milligram of total total daily dose of morphine would be 150 milligram. So 150 milligram. Okay, what would be the oral? What would be the methadone dose for this patient? What would be the methadone dose? 7.5 milligram per day. Okay. Why 7.5 milligram? What would be the conversion ratio? 20:1. Yeah. This patient is taking only less than 200 milligram, but he is 65 years, isn't it? So the conversion ratio, if the patient is taking more than 200 milligram of oral morphine equivalent, or if the patient is more than 65 years old, then we have to use the conversion ratio 20:1. So if you divide 150 divided by 20, it would be 7.5 milligram. So this patient was started on 2.5 milligram TID, that is 7.5 milligram of methadone on 18th of February with the 25 milligram morphine Q4H SOS, tab disacodine 2HS. By the next day afternoon, this patient came to us with a restlessness. Patient was agitated. He was complaining of bad dreams, lacrimation, tachycardia, tremor, loose stools. The caregivers were very anxious. Patient was also very anxious. So why he has these problems? What is the problem? Drug interaction, electrolyte imbalance. Yeah. Anybody else? Serotonin syndrome. Yes. Okay, thank you. So actually, this patient has withdrawal symptoms of morphine. Okay. So we gave injection morphine 3 milligrams stat, and the patient actually slept for 2 hours. And when he woke up, all the symptoms were very well controlled. So what are the opioid withdrawal symptoms? It can affect many symptoms. So if you look at eye nose, there will be pupillary dilatation, lacrimation, rhinorrhea, yawning, tachycardia, hypertension, piloerection, diaphoresis, abdominal cramps, nausea, vomiting, diarrhea, and in the neurological aspect, the patient can have anxiety, insomnia, restlessness, irritability, agitation, muscle or bone pain. So, why this patient has withdrawal symptoms? Probably because when we stopped morphine and started him on methadone, he might not have taken methadone, and he also stopped morphine. So, so because of that, he had withdrawal. So that would be the issue here. So, a few things about withdrawal symptom. When would the withdrawal occur? So, in case of shorter acting opioids like oxycodone or morphine, if they stop taking morphine and 8 to 12 hours after the last dose, the patient can have withdrawal symptoms. But in case of longer acting opioids like methadone, it will take about 24 to 72 hours after the last dose to develop symptoms. So what you have to understand is these are the withdrawal symptoms, even though it is very rare, but it would be good if you can diagnose withdrawal symptoms, because the patient will exhibit many things and we may do something, but it can be simply managed with um, the opioids, or usually we have to give opioids because the patient whom we are seeing would have pain, and we have to give opioids again. So you can manage the patient with methadone, morphine, or buprenorphine, and these are the non-opioids management for opioid withdrawal reaction. Autonomic hyperactivity can be treated with clonidine, diarrhea with loperamide, and insomnia with doxepin or trazodone. Muscle aches, joint pains, headache with paracetamol and ibuprofen, anxiety and restlessness with hydroxyzine. So this is one patient whom I actually saw that withdrawal symptom occurring. I haven't seen any other patients, but the importance is that we were able to pick it up and understood that this is withdrawal symptoms. And there are a few or couple of other observations which I saw with the patients whom we have started on methadone. Patients, when we started on methadone, some of them had diarrhea, but there is no other withdrawal symptoms. So when we change the patient from morphine to methadone, some of them exhibited diarrhea without any withdrawal symptoms. And patients um, uh, usually for many patients doesn't tolerate the syrup, and they say tablet is better because of taste and some other GI discomfort. And I just want to show you this was the profiles of the patient whom we started with methadone during when it was available for the first time in 2018. So this was the patient with a renal cell carcinoma with severe neuropathic pain, and she was receiving 80 milligram of morphine 4 hourly. So we started with a 2.5 milligram KID and gradually titrated up. Patient had good pain relief. And this is another patient with uh, non-cancer pain, vascular ulcer with neuropathic pain, who had no relief with morphine. And we started on methadone 1 milligram BD when patient was admitted. But because there was no reliable caregiver, we had to stop methadone. And there is another patient who had ischemic and neuropathic pain and was started on 2.5 milligram BD. And his pain description was not consistent at all. So it was very difficult for us to assess the pain. So we stopped methadone for that patient also. You can see some other patients. And to summarize what we have been telling is that when this article is available in 2019, safe and appropriate use of methadone in hospice and palliative care, expert consensus white paper. I think all of you should go through this, which is a valuable resource. And now we follow the conversion method, which we taught in the Theo session. Previously, it was very difficult which method we need to use. But this is a very conservative method, and you can very well start patient on methadone according to this paper's equivalent conversions. So in the first year in 2018, when methadone was available, I think we started methadone only for 8 patients in a year. But in the next year, we started about 20 patients. And from that year onwards, actually the numbers of patients for whom we started on methadone went up. So that shows our confidence level increased when we started using methadone over a period of time. But it is also important to understand that don't start methadone for each and every patient. Use it only in selective patients, and you know what are the indications to start methadone. So whenever you get a chance and you see, okay, this is an indication to start methadone, please start patients on methadone. So we have to respect methadone, but don't fear. And the steady state would be achieved only in 5 to 7 days. So don't increase the dose of methadone every day. You need to wait for 5 to 7 days. Morphine, you can actually increase the dose every day. And be aware of medications that has severe interactions with methadone. There are hepatic enzymes inducers as well as inhibitors, and medication that can actually increase the QT interval also. And it would be a good practice to paste the list of this medication in your nursing station, so you can see it every day. And always use a simple medication regime when you start patient on methadone, so that you can ensure that there is no much interaction that is going to happen. And almost all of our patients received only less than or equal to 40 milligram of methadone per day. Very rare patient received 45 or 50 milligram. And I have also had that people who are very experienced with methadone saying that if the patient need more than 40 milligram of methadone per day, then you have to think of any other causes like psychosocial problems and things like that. So don't go on increasing methadone. You have to actually reassess and do the needful for the patients. So this is the morphine tablet available for us. It is 5 milligram tablets, and morphine syrup is also available, which contains 5 milligram in 1 ml. And the cost is a tablet costs about 48 rupees.
कौन कह रहा तेरा घर मस्तानी हो गया?
And a syrup costs 750 rupees. So when you, it is also important to understand or be aware of pharmacoeconomics in palliative care, because most of the time when patient comes to us and tell us that I do not have proper relief of the symptoms, we go on increasing the medications. But we have to actually see whether the patient took it, because many of them would not be able to afford many medication that you are prescribing, like gabapentin, pregabalin, or fentanyl patch. So we need to understand the cost of different opioids. And if you compare the cost of morphine with methadone, it is almost comparable. So with that, I think I will end the session. Thank you.
Thank you so much, sir. We can take up a few questions. Either you can unmute yourself or you can type it in the chat.
Sir, one doubt is that if the patient is able to afford fentanyl patch, and he's having uncontrolled pain on morphine, which will you choose, methadone or fentanyl?
So I would actually you need to assess the pain, and if the patient has a neuropathic pain, or else it is a very difficult question. But considering the interaction and considering the interaction, it would be better to choose fentanyl. But I would also look what is the goals of care. So if the goals of care is comfort care, and if I think, okay, this patient would be getting more pain relief with methadone, if it is neuropathic pain, then I would go for methadone, not for fentanyl. But even before choosing fentanyl or methadone, I would reassess the pain and add adjoint analgesics, and we'll also see if there are any possibility to increase morphine. And is there any palliative oncological interventions like radiotherapy can be done? All this should be, we have to think of this, and then depending on the pain relief, pain and interactions and various things, you have to select between methadone and fentanyl. There is no right or wrong answers.
Sir, there is a question in the chat. Do we need to admit the patient to start methadone?
Okay. So when we started patient on methadone for the first time, I think we admitted the patient uh, when the doses are higher. But if the doses like 2.5 milligram BD or small doses like that, we did not admitted the patient. But now we do not admit the patient. We start patients on methadone even during home care. So actually, the answer is you need not admit the patient for starting on methadone.
One of the formalities you should keep in a hospital when you are prescribing methadone is same as like morphine, or any other additional formalities are required. The double locker, everything is same.
It's same because methadone is also an END, essential narcotic drugs. So morphine is also essential narcotic drugs. So whatever you do for morphine, you have to do it for methadone also. Safe doping capacity and the prescription, the uh, um, name of the opioid in capital letters, the strength of the opioid, the number of tablets you are going to dispense, and how many days you are going to give, then signature of the doctor, medical council registration number, address of the doctor. All these need to be there. All the others same as morphine.
Sir, how to taper down with adjuvants after
Okay.
starting methadone?
Okay. So maybe if patients are on many adjuvants, then maybe you can also take a ECG to see what is the corrected QT interval. And if it is within limits, within normal limits, then I would start methadone, and maybe after 5 to 7 days, I would reduce the dose of amitriptyline. If it is taking 50 milligram, I would reduce it to 25 milligram, and we'll wait for another 5 days, make it 12.5. Wait for another 5 days, stop it, and by that time the methadone dose would be stabilized, and the methadone would take over. So that's how I would taper the adjuvant analysis, like tricyclic antidepressants or anti-epileptic medications.
Sir, how long we can give methadone? Another question.
So most of the patients whom we started methadone is for patients who are having malignancy, and and all of them were in the last stages of their life. So as long as the patient has the pathology, that means if patient is not undergoing any chemotherapy or radiotherapy, then the pain producing or pain generator is there. So you have to continue methadone. So otherwise there will be pain. So you can continue with methadone. And you also know that actually methadone is something which can prevent tolerance also. So you can continue. But in patients who has non-cancer pain, then you should be careful while starting opioids. It is not only methadone, whatever be the opioids, morphine, methadone, fentanyl, you should be very careful because the chance of psychological dependence is more.
So there is another question regarding the titration. Like last session, it was a slower titration, and today it was a little faster.
No, actually, one of the patients, for one of the patients, we increased the dose by 2.5 milligram on the fourth day. So that's what Dr. Pragar is asking. So many people say a methadone dose would be stabilized by third day, even though the classical teaching is you have to wait for 5 to 7 days. So what I would advise you, even though you have seen we have increased the dose by third day, fourth day, it would be better for you to wait for 5 to 7 days before you increase the dose of methadone. So now we have an almost 5 years experience on using methadone. So we are a little bit confident how about methadone. Does methadone got the withdrawal symptom? Yeah, if you stop methadone suddenly, then it will whatever the opioid you are using, and if he has taken opioid more than 1 month, it is better to taper and stop. So that is the case with any opioid. So you have to taper and stop.
So have you used methadone in pediatric age group around 16, 14 years of age, children who has leukemia and or severe?
Okay. Actually, we used methadone in one patient. We do not get much pediatric patients, but a boy who was 14 with having sarcoma, I think, we gave him methadone. But some of my friends who are working in cancer hospitals, they have used methadone safely even in very young children.
Any other questions regarding methadone?
Sridevi, I think in the previous session we had a poll and there were 10 questions. I think with the available time we can answer those questions.
Sure, sir. Sripriya, do you have those questions?
Yes, yes. I'm launching it right now. So all of you will be seeing the poll on your screens right now. So you can just choose the option which you feel is the most appropriate. And once you have submitted all the 10 questions, you just submit the poll. There would be 10 questions in total. So you can choose the option which you feel is most appropriate for each question. The poll time would be limited. Sir, can we fix it at 2 minutes or 3 minutes?
3 minutes, and after that we can discuss the answers also.
Okay, sir.
Or it is mainly when you give higher doses of methadone, and most of the studies on QT interval is from patients who are on oral substitution therapy with the methadone, and they will be on hundreds of milligrams of methadone. So it is natural that they will have prolonged QT interval, which will lead to dosage points. But the doses which we use for pain relief is in the range of 40 to 50 milligram, and it is comparatively safer. Next is methadone has the following action, except agonistic action on opioid receptors, NMDA antagonist, prostaglandin inhibition, PCA-like action, which is the, it is prostaglandin inhibition. Methadone doesn't have action on prostaglandin, but we know that it acts on opioid receptors. All the opioid receptors as agonist, it is an NMDA antagonist, and it also inhibits the reuptake of noradrenaline and serotonin. Fourth one, so everybody got it right. The risk for toxic starts at corrected QT interval of 450 milliseconds and significant at 500 milliseconds. That's right. Okay, which is correct regarding pain relief. Methadone and dextropropoxyphen are safe in chronic renal failure. Methadone and codeine are safe in chronic kidney disease. Methadone and fentanyl are safe in chronic kidney disease. Morphine is the safest opioid in chronic kidney disease. This is the, adult say C. That is methadone and fentanyl are safe in chronic kidney disease. That's right. Dextropropoxyphen will accumulate in renal failure, and codeine is also not advised. Morphine is not the safest opioid because we know that morphine and its metabolites also accumulates in renal failure. So methadone and fentanyl, fentanyl and buprenorphine. These are the three opioids that we can use in renal failure. Next is methadone can be administered through the following routes: oral, parectal, sublingual only. Oral, parectal, is this right? No, it is a C. Oral, parectal, sublingual, subcutaneous, and intravitreal. All these can be used for methadone administration. Morphine cannot be administered sublingually, but methadone can be administered sublingually. Even parectally also, methadone can be administered parectally. The following medications can cause acute interval if administered with methadone: azithromycin, ciprofloxacin, escitalopram, haloperidol, none of the above, all of the above.
All of the above.
Yeah, it's all of the above. Azithromycin, ciprofloxacin, escitalopram, haloperidol. So all of those medications have action on QT interval. So fluoroquinolones, macrolide antibiotics, SSRIs, antipsychotics. Methadone's blood level will be stabilized after, it is 5 to 14 days, because in normal people, it will take about 5 to 7 days. But in patients who are elderly and who has liver problem, it will take about 2 weeks, 10 to 14 days. So the correct answer is 5 to 14 days. So when you start patients who are elderly on methadone, it is better to wait for 10 days at least. Medication that can decrease the methadone levels in blood are, it is dexamethasone. Okay, only one person has selected that word. Following are the indications to use methadone except. It is actually well controlled pain. All others, opiate toxicity, methadone can be used. As an adjunct, we know methadone can be used. For complicated neuropathic pain, methadone is steroid. So in renal failure, it is a safe opioid. When patient is allergic to other opioids, we can use. If the patient has opioid-induced hyperalgesia or tolerance, methadone can be used. In when you control pain, you need not start patient on methadone. Okay. So Priya, you can save this poll.
Sir,
Please save the poll, the results, and we can wind up the session now.
Thank you so much, sir. I understand there are no more questions. So we can wind up today's session. Thank you everyone for participating and interacting during the session and giving your learnings through the poll. Thank you so much, Theo and Dr. Sunil, for sharing your experience in using methadone. I hope most of these participants in this group will be starting to use methadone in the near future, and we'll be there to help you or mentor if there are any roadblocks in using that in the initial days till you get used to the drug. Thank you so much, everyone. Sri Priya.
thank you, Dr. Sunilkumar and Dr. Theo for joining us in this evening to offer that very experience-based session. I believe that those practical cases would definitely be of help to everyone logged into the session today. Thank you everyone for joining and being so much interactive, with a promise that we will meet again in the next session with another interesting topic and yet another panel of very eminent faculties. This is Sripriya along with Dr. Sunilkumar, Dr. Theo, Dr. Sridevi and Mr. Anup signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Bye-bye.